Of all the reasons a patient seeks medical care, musculoskeletal pain is the most common. It is also the most subjective. Unlike a heart rate or blood pressure, pain cannot be directly measured. It cannot be externally verified or immediately quantified by an instrument. To complicate matters, early-stage autoimmune diseases leave virtually no visible trace. Standard X-rays will often show completely healthy bone structure, and basic blood panels frequently return completely normal results. In cardiology, an EKG provides immediate, objective data about the electrical pathways of the heart. Rheumatology has no equivalent first-line technological scan. Instead, the clinician has to rely almost entirely on physical patterns presented during the initial patient encounter. Without a strict logical framework to interpret these invisible symptoms, life-altering autoimmune diseases risk being dangerously misdiagnosed as simple, localized mechanical wear and tear. To process this raw, unstructured patient data, rheumatologists use a strict, step-by-step algorithmic framework. We can think of this as a diagnostic matrix. The first phase of this matrix establishes chronicity and systemic inflammation based entirely on the patient's verbal history. The second phase moves off the chart and onto the patient, conducting a functional, total system physical screening. Finally, this physical data is mapped and fed into weighted, mathematically validated criteria to lock in a definitive diagnosis. This sequence is rigid. Bypassing the physical exam to guess at blood tests first leads directly to false positive serology and incorrect treatment plans. The rheumatological physical examination functions as a data processing engine, converting subjective complaints into the discrete variables required for clinical classification. The immediate objective of the patient history phase is simple: force all musculoskeletal complaints into one of two distinct pathological branches. This table details the categorical features of inflammatory versus non-inflammatory disease. The non-inflammatory branch, like osteoarthritis, is driven by localized wear and tear in weight-bearing joints. Conversely, the inflammatory branch, including rheumatoid arthritis, is driven by systemic autoimmune dysfunction, characterized by morning stiffness lasting longer than 1 hour. This prolonged stiffness is caused by the gel phenomenon. During periods of rest, inflammatory joint fluid actually thickens into a gel-like consistency, requiring prolonged, continuous movement to physically disperse it. The history must also capture extra-articular cues. Symptoms like extreme fatigue, loss of appetite, and low-grade fevers indicate disease activity across multiple organ systems, extending well beyond the primary articular complaint. Identifying these specific markers in the patient history dictates the entire therapeutic trajectory, deciding whether the patient requires systemic immunosuppressive therapy or localized mechanical care. Once the verbal history establishes the primary branch, the evaluation shifts to the physical body. This text outlines the locomotor system examination, initiating with a rapid functional screening called GALS: gait, arms, legs, and spine. Assessing the gait reveals subtle mechanical compensations. How the foot strikes the floor or the pelvis shifts exposes structural defects the patient hasn't noticed. These diagrams demonstrate the precise range of movement required for the arms and legs components. The clinician forces the limbs through these exact arcs, checking for gross symmetrical movement restrictions and visually scanning for muscle wasting. For the spine, the examination focuses on axial rotation and structural alignment. This detects silent inflammatory involvement in the back before it causes irreversible fusion. GALS operates as a high-sensitivity, low-specificity radar. It ensures that a patient complaining of a sore finger doesn't have a massive, undetected defect in their hip or spine. By systematically scanning the entire locomotor system, the GALS protocol prevents clinical tunnel vision and guarantees the diagnosis reflects total body reality. Once the macro screening detects a functional anomaly, the clinician must zoom in to map the exact location and nature of the localized joint data. This text identifies 14 joint areas evaluated during the regional examination of the musculoskeletal system. Symmetrical palpation is mandatory to find synovial thickening. This spongy texture differentiates an autoimmune attack from mechanical fluid buildup. Discrepancies in movement reveal how much cartilage is destroyed. Distinct diseases leave distinct fingerprints across this anatomical grid. Early rheumatoid arthritis heavily targets the knuckles and wrists, but completely spares the distal joints at the very tips of the fingers. The REMS phase successfully translates vague patient complaints into a mappable, precise coordinate system of symmetrical joint involvement. However, physical mapping alone is not enough. To justify starting a patient on potent immunosuppressants, that map requires objective, mathematical verification. This table outlines the ACR-EULAR classification criteria for rheumatoid arthritis. Involved joints are assigned specific point values. Next, high-positive serological blood work adds points. Finally, symptoms must persist for 6 weeks. Reaching a combined score of 6 or higher locks in the definitive diagnosis. Similar weighted systems exist for other autoimmune conditions, such as the SLIC criteria used to diagnose systemic lupus erythematosus. By forcing clinical findings through this strict mathematical filter, rheumatologists eliminate diagnostic guesswork. Reaching a diagnosis initiates treatment, but the clinical loop is not closed. The physician must now track the disease's activity over months and years. The immediate challenge becomes proving whether the prescribed medication is successfully suppressing the immune system, or if the disease is quietly destroying cartilage beneath the surface. This form details the Clinical Disease Activity Index, or CDAI, the primary tool used for this longitudinal tracking. It compresses 4 distinct variables into a single number: the tender joint count, the swollen joint count, and global severity assessments provided independently by both the patient and the physician. The resulting score dictates the reality of the patient's condition, strictly categorizing their current state into remission, low activity, moderate activity, or high activity. Generating this continuous loop of numerical data allows for strict treat-to-target strategies. Medications are aggressively titrated and adjusted at every visit until the CDAI score drops firmly into the remission bracket. Activity indices take the abstract concept of feeling better and convert it into reproducible clinical evidence. The practice of rheumatology is an exercise in structural deduction. It requires taking scattered, unpredictable physical suffering and organizing it into a targeted intervention. The patient's history sets the vector. The GALS screening establishes the coordinates. The REMS grid provides the map, and the mathematical criteria verify the target. This layered methodology is required to manage diseases that impact the entire human system, from the skin and nails to the heart and lungs. Even in an era defined by advanced diagnostic technology, a highly calibrated physical examination remains the most effective tool for capturing that complex systemic data. Structuring the chaos of subjective pain into objective data provides the only reliable path to preserving a patient's life and mobility.